Let's now take a look at my standard approach for assessing and treating an unconscious patient without a pulse. Over the semester and with practice, I have developed my own approach that is very similar to other basic approaches, but I've laid it out in a nice flow diagram that helps me best to understand what I need to do in that situation. It starts off like any other case with standard precautions, that is, gloves, goggles, overalls, and all the necessary safety implications. Moving on to the primary survey. Before arriving at the scene, it's important to discuss with your partner who's going to take on what positions as a rough estimate. Of course, this can change during the scenario, but if you have communicated with your partner what both of your expectations are beforehand, there'll be less chance of confusion and greater teamwork during what can be a very high stressful situation. Things like who's going to start on CPR, who's going to start on ventilations, and keeping up that good line of communication is really important. Just like every case, it starts off with a primary survey. That is first assessing the dangers. If there are any dangers, remove them or negate them. Moving on to a response. Obviously, if it's in the case of an unconscious pulseless patient, there will be no response. That is a verbal response, or moving on to elicit a response to a painful stimulus such as a trap squeeze or a sternal pressure. Following dangers and response is a quick airway check. This isn't an extensive look because there are other priorities that need to be addressed, but a quick airway check, look down the patient's airways, removing any highly visible foreign objects. A quick assessment of their breathing, looking for rise and fall of the chest and listening for breathing sounds. And finally, a pulse check to check for any form of circulation. Since the scenarios we completed with the unconscious pulseless patient, from this point is where it differs from the simple original primary survey, and we move on to addressing the situation. I stress again that the breathing and airway check need to be very quick. Following a circulation check, move on and start CPR immediately. One member of the team begins CPR at the usual rate and rhythm of going for about 100 per minute with good depth and proper chest recoil, while the other member of the team attaches the cardiac monitor onto them, ensuring that it's attached in the correct way and will not interfere with the CPR. After attaching the cardiac monitor, it's important to perform a 6-second lead printout. The next step after performing this printout is to analyze the rhythm. It's important not to take too long on this because it needs to be a quick decision, but at the same time, the worst thing you could do is rush the decision and go down the inappropriate pathway of treatment. It's a good idea in this part to make your own decision, verbalize it to your partner, and get a second opinion as well, and make sure you're both in agreement on what the plan of action is. If it is a shockable rhythm, this is where the time when you would shock it, so you would move it up to 200 joules biphasic monitor or a 360 monophasic monitor and shock for an adult. In the shocking process, it's be sure to verbalize with your partner the words stand clear, make eye contact with them, do a quick visual inspection of the rest of the patient, ensuring that there's nothing touching them that would be harmful to the shock or to any of the bystanders. Get that verbalization back from your partner, all clear, one last visual inspection with the finger on the charge button, charge, and deliver the shock. Of course, I stress that this is only if a shock is appropriate for pulseless VT or VF. If no shock is appropriate, this step is moved and skipped. The following step is straight back into CPR after a shock or after a print rhythm, and to begin ventilations. This is ventilating at a ratio of 30:2 for an unconscious adult patient receiving CPR, with your partner verbalizing from 25, 26, 27, 28, 29, 30, and then verbalizing 1 breath, 2 breath, and then back in. With beginning ventilations, you need to make sure that you're actually getting rising full of the chest and a good seal. This was difficult during the semester due to the mannequins, but if necessary, you must insert an OPA or an LMA. It's also important at this stage to call for backup if necessary. Rather than doing as much as you can and realizing you need backup later on, it's much better to call for backup early and help and get Michael or possibly a second crew to arrive as soon as possible. This system is completed for 2 minutes, so complete your 2-minute cycle with ventilations and CPR, and then it starts to move into more of a cyclical nature of what you need to do going forward. So as you can see here, now, as I said, it becomes into more of a full cycle. So once you complete your 2-minute cycle, you then move into performing a 6-second printout like we did before, and making sure to swap positions with your partner due to CPR fatigue. So it's important, that's a really important step, is that at the end of the 2-minute cycle you perform your printout and swap positions. Then once again you're responsible to analyse the rhythm, get a verbal agreement with your partner, and then further shock if appropriate. If not, continue with CPR and ventilation, or if a shock is appropriate, follow the same steps of getting verbal confirmation that it is all clear and safe to shock, and then continue with CPR and ventilations. However, before we move into this cycle, we need to add one more step in, and as you can see here, another loop has been added onto the circle. This is where the IV needs to gain access. There is some debate about gaining access and administering adrenaline for Ambulance Victoria require it before the second shock, but that is not consistent with specific for AV or not. So for now we'll do as if it was Ambulance Victoria guidelines, just to simplify things. So this must be done before or prior to your second shock. So following your first shock, you can see in the flow diagram you perform your 6-second printout, swap positions, analyse the rhythm once again following the same steps. That's that first shock if appropriate. Then we move on to continuing CPR, but instead of following the normal loop, we have to gain IV access with an appropriate gauge needle in an appropriate location, and then the process of administering adrenaline. AV say that adrenaline is administered in 1 microgram every 3 minutes. So administering that first load of adrenaline, and then we can move back into continuing our CPR, ventilation and adrenaline administration once every 3 minutes. Following this, we complete our 2-minute cycle and go back into the same rotation. And this brings us to our final simple loop that helps show the end result process of what the cycle should look like. And that is completing your 2-minute cycle, performing the 6-second lead printout, swapping positions, verbal confirmation and analysing the rhythm, shocking if appropriate, or if not, continue CPR, ventilation and adrenaline administration every 3 minutes. This is a loop that is very sustainable and needs to be continued for as long as it requires until the return of ROSC, the return of spontaneous circulation, until further backup arrives. So that's my flow diagram that I believe helps me understand the best how to respond to such a situation and get into a cycle that helps me make sure everything has been completed that needs to be done.